I'm going to introduce myself because I always think it's hilarious to make someone else memorize my bio. I'm Dr. Sophia Yen. I'm one of the doctors here at Stanford in the teen and young adolescent clinic, and we see people from age 12 and up. When it gets to college, we make a decision. If you're going away for college, I'll keep you. But if you're staying for college, I figure you can go see the doctor you're going to see until you die. So then we transition you to adult medicine, and then you can go see the doctor you're going to see until you die. Because I believe in long-term relationships, and so why not start that one up as soon as possible? Though I am sad to lose them after all these years, but I'm also okay keeping them as well. So adolescent medicine is a subspecialty of pediatrics, internal medicine, or family practice. I came to it through pediatrics, and I just like it because we call it sex, drugs, rock and roll, which is mental health, a little sports medicine, and a little acne. And so definitely periods and acne are in that area. What's interesting about polycystic ovarian syndrome is that you can come from it from the endocrinologist point of view, and they'll treat it with one medication, from the gynecologist point of view, and they'll treat it with a different medication. And then I'm the middle, so I'm okay with either one, depending whichever one that you like. I went to MIT. I've got my ring on today, my beaver ring, and my uterus necklace. I went to MIT for undergrad. I went to UCSF for medical school. I did my residency at Children's Hospital Oakland, and then I went back to UCSF to specialize in teenagers, so that requires another 3 years of education. And then I also did a master's of public health at UC Berkeley, because my goal is someday to be the first Surgeon General to say masturbation without being asked to resign, which is what President Clinton did to Jocelyn Elders, who was the first African-American Surgeon General, which is unfortunate. But I just hope for a world in which we have comprehensive sex ed and access to confidential reproductive health care to prevent unplanned pregnancy. So that's background on me. I'd love to just go around and hear about if you have any particular concerns so that I make sure I address them, or if you just want to tell me, okay. I know that you represent teen program at Planned Parenthood. I know that you guys are just here to learn. Okay, great. Any particular concerns that you have? None? Okay. And you guys are here just to come listen in and...
Well, we have a granddaughter who has been diagnosed with this, and so we want to know what to expect.
Great, awesome. I'm so glad that you're here supporting her and learning for her, and I hope that this will be helpful. And then a mom that has another daughter that has PCOS. And part of this was brought on by a mom who hopefully will show up later today, wanted to put together a support group for young women with PCOS. Because if you go on the internet and you do PCOS, it's always talking about infertility, which is not relevant until you're like 30 or so, 35. And so one pearl that I have to offer you to start with, there is Young Women's Health, which is Harvard's website, and they have a serious focus on PCOS. So there's like different articles on the definition of PCOS, on how to treat it, by nutrition, by medications, all sorts of stuff. So that, I would say, is the one thing you should walk away with as a resource, is Young Women's Health PCOS. The other thing is each other. If you're interested, I don't know, we have a sign-in sheet, and maybe on there we can have a column where you indicate I'd like to be contacted in the future if you do start a support group. And that's really one of the reasons we're doing this today. So hairy, acne, and irregular periods. Is it PCOS? Certainly teenagers all will have a bit of it. PCOS is polycystic ovarian syndrome, and because it's a syndrome, as I was explaining to someone here earlier today, it has many different etiologies. It's kind of a wastebasket that we put all these different things together. So as I was saying, there are skinny PCOS, there are overweight PCOS, and there might be some sort of hypothalamic injury kind of PCOS. So, but all of them share the same common 3 traits, which is the hairy, the irregular periods, and the acne. And so you do need most of that criteria in order to fit this. It is the most common endocrinopathy in women, affecting 5 to 10% of adult women. So that's 1 out of every 10 women, but we rarely hear about it. And I think part of it is that women are put on birth control pills oftentimes to regulate their period, and then they're on it for so many years that they forgot why they began to begin with, but really it was because they had underlying polycystic ovarian syndrome. And some women just go on birth control for birth control, so then it hides it, and they never knew that they had it to begin with. Because by putting them on birth control pills, you're turning off their ovary, which is oftentimes the hormone is making more male hormone, and that's what causes the disorder. But by turning it off, you're hiding the disease. It affects about 5 million women in the United States. Most of the symptoms begin during adolescence, and it's overlooked, it's under-recognized. Like I said, it's a syndrome, so it's a mix of different things. There is a genetic component, so certainly if your mom or your aunt or your sister has it, then it's more likely to happen to you too. And then there's epigenetic and environmental factors that can bring it out. And as I mentioned before, there's obese PCOS, and then there's normal weight or lean PCOS. It runs about 90% on the overweight side and 10% on the skinny PCOS side, or regular weight PCOS. Yes, you can interrupt anytime with any question.
Obesity, are you talking about above a BMI of 24.9, or okay.
So obesity, yes. So there's overweight and then there's obesity. And to me, it's a spectrum. The further you get towards obesity, the more likely you're going to have PCOS. And if we pushed everyone to morbid obesity, then I think the prevalence of PCOS will be a lot higher. And it's simply it's an insulin-related state, and I think we'll hit it up maybe on some other slides later on. But the insulin also increases the change from the female hormone to the male hormone, and it's this excess androgen, this excess male hormone that causes all the effects of PCOS. So the most common presenting signs and symptoms in teenagers is irregular periods. And certainly teenagers can have irregular periods within the first 2 years that they get their period. Within the first 2 years, we're like, yeah, whatever, it doesn't matter. Come back in 2 years, and then we'll see if you're irregular. But if after 2 years of the first period, it's still irregular, then that is a red flag that we define it as start looking for abnormal stuff. Weight gain, and part of it is adolescence, you gain weight, you're growing taller, but it's proportional extra weight gain in relation to your height. And then the cysts, you don't know about it unless you have some sort of abdominal pain or if they do an ultrasound. So that's really kind of secret, hidden, nobody really knows about it unless you do an ultrasound. The associated signs and symptoms, like as I mentioned, it's the ovary making excess male hormone, and so you'll have excess hair growth on your face or body, and we call that hirsutism. Thinning scalp hair, not so much. In teenagers, mental health problems, that isn't really part of the definition, but some people have thrown it in there. Certainly body image and poor self-esteem, but I wouldn't say so much depression. The fertility impairment, what that is what happens is because of this derangement of the hormone, every month you have a whole bunch of eggs that come out, and then one wins and then one pops out. But because of the extra male hormone, it doesn't pop out. And so it's just these things building and building and building. And actually in our radiologic findings, we call it a string of pearls. So normally it's just one and it pops, but there's one, it gets stuck, and then another one comes, and then another one comes, and another comes. And so you can envision a normal ovary, which is, we think of it the size of an almond, is getting these little things and a little heavier and bigger, and it has a greater risk of twisting. But the infertility part is if you don't pop out, you can't get pregnant. And so that's where the infertility comes from. It's not that they couldn't get pregnant if we could make the egg pop out. And so we now have the technology to make the egg pop out. So the infertility is just without medication, yeah, it's gonna be a hard time getting pregnant. But with medication, we can totally help you get pregnant when the time comes.
So it has actually nothing to do with the egg. And I don't know why I heard someone talk about the infertility. It was because it changes the egg to not make it
viable or something. Yeah, so I mean, so the question, in case the audience didn't hear, was that somebody had heard it was the egg was rendered bad and therefore you couldn't have a baby. And I think maybe it's just, I like to visualize it. And so the egg is perfectly fine, but the egg couldn't get out. And if you can't get out, you can't get pregnant. But if we poked a hole in there and the sperm got in, that wouldn't be good because it'd fertilize here. But if it came out, then you'd be fine. Yeah, so the eggs are fine, they just can't get out. So we have to help them get out by normalizing the hormones. And we can talk about the medications that will help do that.
Question?
Yes, please.
I just realized polycystic
Ovarian syndrome.
Okay. I don't think I have it,
Yeah.
but of the 9 children, siblings,
Yeah, that you have.
5 4 have died,
Uh-huh.
and 1 is on the list right now. She's any day, hopefully, a kidney, but polycystic kidneys and liver.
Disease.
Is that related at all to this?
Not to my knowledge. So the question was, is polycystic kidneys related to polycystic ovaries? Not to my knowledge, but definitely the two words, polycyst, little sacs of liquid happening in them. It's describing something, but not describing something that has the same genetic or molecular basis. But same words. Yeah, good question. And there's the associated risk of diabetes. That's mainly from the extra weight gain, but also this abnormal insulin receptor. So that's part of what they think it is too. So if you have anything that's abnormal with insulin, then you have a risk of diabetes. And they believe that it's insulin's action on the ovary in some people with an extra sensitive receptor or something that turns this into the male hormone rather than the regular functioning. And so one way you can get a lot of excess insulin is by extra weight gain. And so for a lot of the overweight PCOS people, if you lose 10% of your body weight, everything goes back to normal, because anytime you lose 10% of your body weight, it helps with hypertension, it helps with diabetes, it helps with all sorts of things. And so if somebody has the overweight kind of PCOS, losing 10% will then decrease the insulin, which will then decrease the effect on the ovary. Hypertension, again, that comes from overweight. The hyperlipidemia also comes from the overweight. And we can mitigate the risks with correct management and correct diagnosis of this.
Question.
Yes.
If the eggs are making that string of pearls
Yeah.
and loading up there for 10 years,
Yeah.
is there damage being done for that, or do they
Well,
know enough about
usually it can reabsorb, but that might also be the quote infertility issue that, over time that you're just crowding and stretching out this ovary and distorting it. And that might be why, if you let this go on for too many years, that it may be harder when you get older to get pregnant. So just about hyperandrogenism. So a lot of male hormone in teens. It's actually perfectly normal in a regular teen to have to have acne. As we know, 20 to 70% of teens with no other problem, no health problem, no diagnosis, no nothing, have acne. And 15 to 25% of adults with PCOS have acne. So that's a little less rare. Normally you should outgrow your acne, but certainly I'd say on general, 5% of adults still just continue the acne, but an extra percentage have it if you have PCOS. The hirsutism, which is the hairiness, it develops slowly and may take many years to show up, and it may not be apparent in the early years because it's just a slow growth. It's present in approximately 60% of teens with PCOS, and part of it is because it's part of our definition. If you don't have the hairiness, then we don't count you as PCOS if we can't find other evidence of hyperandrogenism. The distribution and number of terminal hairs, so there's the baby fine hairs, those are not terminal. It's the thick ones, when you get to that razor shaving male side, are influenced by ethnicity. And so for an explicit example, Taiwanese Americans aren't as hairy, but my husband's Korean and they are hairy. So it's just different by ethnicity. The Ferriman-Galwey scores based on studies in adult white women. So their standards may be different from a Mediterranean woman, maybe different from an Asian woman, maybe different from an African American woman. But I'll show you that is the grading system that we use just to normalize it. And this is what you are on a scale of 0 to 36. Adolescents often hide unwanted hair. So a patient will come in and I won't think of PCOS because I'll look at her upper lip and I'll look at her and I don't see anything, but she shaved or she nared or she picked or she lasered, all that kind of stuff. So sometimes the patients have to be proactive and bring this up with the doctor because the doctor tried but didn't see anything. So just kind of okay, that's fine. Doesn't meet the criteria. This is the Ferriman-Galwey score. And so as I mentioned, 1, 2, 3, 4, 5, 6, 7, 8, 9. There's 9 different areas that you can have hair. And it's graded from a score of 1 to 4. And certainly you can have 0. But you can see the upper lip. You can see the chin. You can see the chest. You can see along from the breast to the lower pubic area. You can see the pubic area, as we call it, crawling up from below, and then arms, legs, back, and around the buttocks. So these are different areas that you can have excess hair.
So what are you saying is if it doesn't show up in any of those spots, you don't have it?
So part of the criteria for polycystic ovarian syndrome. One is irregular periods, and then the other one is hyperandrogenism. And it can be manifested as hairiness, or it can be manifested as acne, or it can be simply a lab test. If we check your labs and you have a high amount of free testosterone, that qualifies as well. But this is how it has traditionally manifested. And you can tell from this drawing, it's an old drawing, so I don't know, probably 1950s or 20s, you know, something like that.
I know a lot of older women
Yes.
who shave. Does that have anything to do with this?
If they're on the heavier side and they develop the hairiness with irregular periods, then definitely could be related to that. And as we all know, we're having an increasing epidemic of obesity nowadays. And so as we grow older, we should not be gaining any more weight. But if we continue to gain weight, then you have the risk of polycystic ovary disease, more male hormone-ness and more hairiness going on. So the question was, she noticed a lot of older women shave. And so I'm just repeating it for the video.
I mean,
All of
shave
you
their
know I can hear.
face,
Yeah, shaving the face and other things. So it'd be,
hair.
yes, it's particularly hair here and in the back and other places. That's unusual. And if you have that, I would, you know, consider getting a testosterone checked. And as an older woman, and you could, it depends, assuming you still have your periods, then we could treat it with hormones and turn off the whole hormonal mechanism. If you don't have periods, then that would make less sense. But if you have periods, then we can turn off that system so it stops making extra male hormone.
Why does it make less sense?
Well, because then you're menopausal, and so there's nothing to turn off. That's what I'm thinking. Yeah. I don't know adult medicine as well. I'm adolescent. So my peak is 25 years old. But I did do medical school. So I know a little bit of adult medicine. The associated medical conditions are obesity, hypertension, insulin resistance, diabetes, hyperlipidemia, fatty liver, obstructive sleep apnea, the hairiness, and the acne that we talked about. I'd say all of the top is more the associated with the obesity and the insulin resistance. Adult consequences of PCOS, if untreated, are infertility, endometrial cancer. So what happens is the lining of the uterus builds up, and then when that egg pops and it doesn't get fertilized, then the progesterone level falls, and then the lining sheds. But in women who don't pop, you don't have the fall, and then you don't have the shed. And so if you don't bleed regularly without any medication, then you risk endometrial cancer, because the endometrium is growing unopposed, as we call it, unopposed estrogen with no progesterone. The only way to get progesterone is if that egg pops out and then it doesn't get fertilized, then the progesterone happens. And then the fall of the progesterone causes the lining to shed. And so that is the #1 risk of untreated polycystic ovarian syndrome. The hard concept to convey to most people is if you're not on any medication, you should have a period every single month. If you don't have a period, we need to look for something, and specifically PCOS or thyroid or anorexia or something else like that. However, if I put you on a medication, periods are optional, because then I'm controlling it, and then we're simulating pregnancy in general is what we're doing. We tell the body it's pregnant, so the body's like, oh, I don't need to pop out an egg every month. I don't need to just do anything because I'm pregnant. And so that's kind of the way I like to think of the way birth control pills work. So very hard concept. If you're not on any medication, you should have a period every single month, or we need to talk about it and figure out why. If you're on medication that we put you on to play with your periods, then periods are optional.
Is there a connection between endometriosis and PCOS?
There might be, but I'm not aware of it. The two are separate. Endometriosis, I think they're still studying it, but the idea there is that there is overgrowth and it flows out, and one could see with PCOS that might go there. But I think it's the ability to flow out or the ability not to flow out, but that's purely conjecture. I don't know what the literature is right now on that. Cardiovascular disease is the whole association with obesity and hyperlipidemia and that kind of stuff, and as well as obstructive sleep apnea can cause permanent heart damage if you don't treat that. The insulin resistance, anytime your insulin is messed up, then you have diabetes, and the metabolic syndrome is related to insulin resistance, that. The goals of the treatment is to normalize the hormonal state and its effect. And as I just said before, without the egg popping out, you have unopposed estrogen and the endometrial cancer risk. The hirsutism and acne is mainly cosmetic, but why not treat that, and why should young people suffer through that unnecessarily? The metabolic status is to treat the insulin resistance and its effects via controlling the weight. And so the weight loss, 76% of women with PCOS in the US are obese. A 5% weight loss can decrease the circulating androgens, improve the glucose and lipid profiles, and decrease the hairiness and lead to spontaneous resumption of menses. And this has actually been studied in teenagers, not just adults, because I had a whole bunch of studies and I deleted them because they were very technical, but they might sneak in depending if I didn't delete them all. So weight loss by change in diet and exercise. The plate model, are you all familiar with that, or a little bit? I see a lot of heads nodding, a little no. Okay, for the no, the rest of you, this will be a refresher. This is your plate. Half of it should be fruits and vegetables, a quarter of it maximum carbohydrate. And so a lot of families will do tortillas and rice. Tortillas or rice, but not tortillas and rice. Or if tortillas and rice, no more than a quarter of whatever meal. So if you have a burrito with, you know, the way burritos go, rice and the wrap, it's not a quarter. It has to be a quarter maximum carbohydrate. And then a quarter minimum of every plate protein. And so I think of it as one of these kinds of picnic plates. When I get a picnic plate, I usually put rice, if there's some meat, and maybe there's some vegetable. That is totally the wrong portion. It needs to be half fruits and vegetables, a quarter max carb, a quarter minimum protein. All right, and then some dairy. Another resource I want you all to note is Brian Lian, our nutritionist here, has a YouTube playlist. So if you Google his name, BryanLian, and Nourish on YouTube, there are 8 to 10 basic nutritional videos. One is on the plate model, another is how to read labels, another one is how to pick your snacks, another one is how to know when you're full. I think in today's society, we eat until we're full, and we really should eat until we're not hungry. Right? And all of us, another random tip for you all, can eat as much as we want in 20 minutes. That's why there's hot dog eating contests, pizza eating contests. We could all just in 20 minutes. But after 20 minutes, we're like, oh, that's too much. So we need to slow down our eating. And so there's this whole movement for slow eating and eating together as a family so that you stretch every meal to at least 20 to 30 minutes so that you have time for this stretch in your head and your stomach to talk to each other and be like, you ate too much or something. Another kind of nutritional tip, I work here also in the morbid obesity clinic and the weight clinic as well, is if you can start every meal with salad or soup, because the salad, they've actually shown if you start with a fruit or vegetable, it blocks absorption of bad things and there's less inflammation in your blood after that. And the specific example they gave is they had a group of people and they gave them Egg McMuffins. And then they gave this group a glass of juice, fresh squeezed orange juice, but I don't believe in juice, I believe in fresh oranges. Eat your fruit, don't drink it. But envision a fresh orange and the Egg McMuffin. And then they drew both of their blood a half an hour afterward. The group that started with the fruit didn't have as much inflammatory markers, risk for cardiovascular badness, because maybe the bacteria were like, oh, we like fruit, we don't need to get so much of this stuff. And then this one had more inflammatory. So I would recommend, whenever possible, with whatever meal, start with your fruit, start with your vegetable, your salad, and then go to your main meal. So even if I'm getting salad and thing, I'll always like 2 bites of salad before I go to this thing, just for the god of, making less inflammation. The other thing with soup is, and salad, I say, if you can't see through it, you can't eat it, except for minestrone and miso soup. So Caesar, ranch, French, Thousand Island, okay, balsamic, I'll make the exception because it's balsamic. But oil and vinegar, vinaigrette, those things are good. Italian, you gotta watch, because if you turn it around, sometimes some of them have high fructose corn syrup, AKA sugar. So anywhere they added sugar, okay, to the best of your ability. And then soup. Soup, I found out miso soup has 0 calories. A ton of sodium, but 0 calories. But I don't know if you've all had miso soup, but it's very comforting and warm, and you can throw in extra vegetables against your will you don't know about, and then throw in some tofu or something like that. and it fills up space. And then everything you eat afterwards expands and fills up space. So you feel full. We don't want you to be sad. We want you to be full. And so if you can start every meal with, it's kind of going back to traditional, every Asian meal starts with a soup. And I don't know, well, part of it, we can't drink raw water, you get diarrhea in those countries at that time. But also it fills up your stomach and then you eat less.
You're saying use the miso soup?
Yes. So I allow miso soup, I allow minestrone soup, but cream of blah or chowder, anything you can't see through, except for minestrone, miso, and balsamic. The others, you have to be able to see through it. So I had a patient and her mom works at McDonald's and she got salad, but what did she do? She put Caesars or ranch on it. I had a friend, she brought me Caesar salad because she knew I didn't want Costco, but she brought me Caesar salad. And I was like, was there a balsamic or a vinaigrette option? So, it makes it hard. But you do the best you can. And some people just squeeze some lemon, or I just have really good olive oil and really good vinegar, or my answer to everything is garlic. Smash some garlic on it, it's good. As much salt and pepper as you want, as much oil and vinegar as you want, but no ketchup, because again, high fructose corn syrup, no honey mustard, but salt and pepper salsa is great as well. So all these kind of condiments are good. Exercise. So exercise is, from my experience, 10 plus years in morbid obesity clinic, has never caused anyone to lose weight loss unless I had one boy find soccer. So he did soccer 3 hours every single day and 5 hours on the weekend. So if you're doing 3 hours every day of cardio and 5 on the weekend, I will give it to you by exercise. But outside of that, it's 95% what you eat and 5% exercise. And so this book, 8 Minutes in the Morning by Jorge Cruz, he used to be morbidly obese, and he was able to get to this just with diet and exercise. But what's really interesting is in the front of his book, there's these white pages, and then there's these dark pages. And the dark pages is the exercise. But you have to get through the white pages to get to the dark pages, and the white pages are nutrition. So he brought you in with exercise, but really he's teaching you his nutrition in the beginning, and then he has exercise. And I like the exercise because I have many patients who can't afford to go to the gym. I personally don't believe in the gym. I think you should get your exercise in life or in your house or chasing your children or whatever. I don't refuse to pay money, but if it motivates you, then go right ahead.
This is a book we can buy?
You can buy it. So I buy it used all the time for my clinic. It's literally 1 penny, and it's $3.99 for shipping and handling. But just go on Amazon, buy it used, 1 penny, $3.99 shipping and handling, or go to the library. So it's great, the nutrition part, and then it's great, the physical activity part. And physical activity has been shown to decrease your stress, and therefore the lower your cortisol goes up with stress, then your better ability to lose weight, and it also helps you maintain weight. So if you lose weight, you want to maintain that weight loss. So doing the exercise does help that. But it's very, very rare to get it from exercise alone. It's really 95% what you eat. And then a pedometer. So I don't know if you all the phones now have a pedometer that can check how many steps you're taking. We're supposed to get 10,000 steps a day, which is 2 miles, which is not unreasonable. I used to wear a Fitbit. You can also buy a pedometer at Daiso. If you guys know about Daiso, it's the Japanese dollar store. They have a pedometer there for $1.50. So if it drops in whatever, you just buy another one. The key with pedometers is to wear it in line with your knee, not on your side or not in the middle, so that way you can track it correctly. And then what I do is at the end of the day, if I haven't hit the right thing, then I'll just play a game of tag with my kids and we'll run around the house until I've gotten to the right number of steps. Or I really love video games. I used to think video games are evil, and they generally are, and you shouldn't do more than total media time of 2 hours a day. But there are good video games now, right? There's Wii, and then there's Just Dance. And so my little one, or not so little anymore, would go up to Grandpa and go, "Grandpa, what was it? Poker face." And he'd be like, "What?" And she's like, "Poker face." And it's Lady Gaga singing Poker Face. And he would hook up the game for her, and the two of them be all dancing together. So Grandpa and little one got exercise. And so you could get your 8 minutes every day.
I thought it was 6,000 steps a day. That's my default on my phone.
No.
6,000 is what people average. What we suggest is 10,000. And in New Yorkers generally get it. When I was in New York, you could walk in everywhere and do that, yeah. So, in Italy too, and Europe in general, because the United States, I don't know if you ever saw the movie LA Story with Steve Martin, we literally will drive 2 blocks, right? But other people would walk that. Or like, I'm now a parent and I'm like, why are we driving our kids to school and dropping them off? Back in my day, I was a 2nd grader. I looked it up and I think I walked 1.1 miles as a 2nd grader across an overpass, across a freeway. I made it home fine. But now we're all just trucking them and wasting gas. So we need to go back to group, we call them walking school buses. If one parent would take it on and walk them all, or if just the 6th grader would take responsibility and take them all, something like that. So I did leave in some of the research studies. There was a lifestyle modification program where they had 16 sessions with the patient and the parent. It was a rolling group admission. They had a lecture series for one, and then they had a behavioral support with peer counseling, electronic communications, and they had structured group exercise weekly. They aimed for a diet intervention of 500 kilocalories deficit and an exercise of 30 minutes a day. The results showed that it increased their sex hormone binding globulin 2 times, which is a good thing, but not as good as if you just took a birth control pill. So the sex hormone binding globulin, what that is it's a protein that circulates in your blood and it binds the testosterone. And so the more of that, the less circulating testosterone, the less hairiness, the less whack on your ovary. So the higher we can get the sex hormone binding globulin, the better. And one of the ways I diagnose PCOS is if they have high free testosterone or low sex hormone binding globulin, then that tells me. The test is free testosterone or sex hormone binding globulin. So that's a very more specific subtest. Some doctors will just get total testosterone, which isn't as accurate as free and the amount of sex hormone binding globulin.
So say that one more time.
Yes, so free testosterone and sex hormone binding globulin, or SHBG. But if you say testosterone and SHBG, they'll get close enough to the right test. Yes, sex hormone binding globulin. They did a diet study for 3 months. They originally started with 24, and 33% dropped out, because that happens. They had a low carb group, they had a low fat group, and then they added 30 minutes of aerobic exercise with the nutritionist meeting them every 2 weeks. The total group lost 6.5% from their baseline, and so it's doable. This is just showing you other weight loss methods by medications or surgery. Surgery we would not recommend unless somebody was morbidly obese, which would be a BMI of 40 or a BMI of 35 plus some morbid comorbidities such as sleep apnea or diabetes or other things like that. Orlistat is a traditional weight loss medication, and they've shown that they can decrease their weight by 3.8% or their BMI by 4.5. Metformin is a medication that actually sensitizes your body to insulin, and that is one of the common treatments for polycystic ovarian syndrome from the endocrine point of view. The gynecologists like those birth control pills, and that also causes a negative 5% weight loss in the bariatric surgery, because I do bariatric clinics, so I had to throw that in.
Sort of a silly question, but
Yes.
that thing decreased the BMI by 4.5%,
Yes.
decreased weight by 3.8%.
Yes.
What did it do? Made him grow taller? Why aren't they the same?
That is a good question. Kilos per meter squared, and if it's the kilos, it should be the same.
Oh, unit squared. Okay.
Yeah,
Right.
maybe some metered squared thing. You're right, though. It should be the same. It doesn't make sense, because the only thing that changes is the kilos. Yeah, good question. Good catch. Adults, 40% drop out of intense lifestyle modification. In a PCOS adolescent study, 30% dropped out, 40% attended less than 50% of the sessions. Therefore, there wasn't any weight change in those patients.
Oh, can I ask a question?
Yes.
Even though you're talking about adolescents right now, you just included adults. Do you take care of adults?
I do not take care of
No,
adults.
Are adults taking care for this?
Yes.
If they come for the first time
Yes.
with
with
Maybe
these
I have
symptoms.
this.
They can totally bring this up with their regular doctor. And so if I didn't make it clear, polycystic ovarian syndrome is much more established in adults, and it's actually harder to diagnose in teenagers because teenagers already have hairiness. Teenagers already have acne. Teenagers already have irregular periods. And so it's like, is this normal, or is this all three together, and therefore we've hit the threshold for polycystic ovarian syndrome? But it has been traditionally diagnosed in adults, and more recently we're starting to diagnose it in teenagers because we want to recognize it earlier, so that way we can prevent the long-term effects of it. So it's much more common to be diagnosed in adults than it is in adolescents, because we're just hoping they'll grow out of it, or like, you know, it's just part of normal teenager. They all have all these symptoms, but there's thresholds for all this. They have extra acne, they have extra hairiness, or their periods have been irregular greater than 2 years. So there's just, as an adolescent medicine specialist, that's my job to know. If your periods start late,
Yes.
if your periods start late, they've shown the later your periods start, the longer they'll be irregular, which is interesting. So if they start early, then they get regular fast. And I think it's a sign of just a healthy system that you started normally. And so if it took you 4 years for it to happen after everyone else, and something's messed up with your system, and so it takes a lot longer to get it to normal. So that's...
The normal now age.
The normal age to get your period on average in the United States is 12 and 12 and a half. And if you don't get your periods by age 14, then we need to start doing some workup.
Okay.
Yeah.
Thank you.
So birth control pills are the first line of medical therapy. They block the LH. So when we draw blood tests, we do an LH to FSH ratio. And if it's greater than 2.5 to 3, then it's abnormal. And so what it is this luteinizing hormone is just getting bigger and bigger and higher. And so the birth control pills stop that from happening. They also increase, as I mentioned before, the sex hormone binding globulin, which then decreases the circulating amount of testosterone, which causes the hairiness, the acne, and other side effects. And birth control pills also inhibit 5-alpha reductase, which is the final step of activating testosterone. It's the first line medical treatment in adolescents. It controls your periods. We can either make them happen every month, or we can make them happen never. The main thing is that we're throwing progesterone, whereas before, without the birth control pills, it's just unopposed estrogen. So another way to treat it in the past, if somebody's really against taking a pill every single day because it's a pain in the butt or they just don't want to do it, is to induce a period every 3 months just to clean it out. And so what we'll do is give them 5 days of progesterone, and then when the 5 days are over, the progesterone falls, and then the lining comes out as well. So that's an alternative treatment. But for me, I'd rather control the hormones the whole time than just every 3 months kind of scrape it out. But meanwhile, the hormones are all whacked out. Yes.
What if you're taking the birth control pills?
Yes.
And you still have the hairiness or the acne? Is that just...
Yeah. So if you're taking the birth control pills and you still have the hairiness or acne, then we aren't controlling it enough. And so there are adjunctive treatments that we can give to it. There are anti-estrogens that we can do, and there's also more aggressive birth control pills. So in general, all birth control pills will make people's acne better. In general, all birth control pills will decrease the androgens. But there are some that bump the sex hormone binding globulin up even higher. And so there's two in particular that I like. In general, if it were me or my daughter, I would start with a norgestimate-based birth control pill because that increases the sex hormone binding globulin. Norgestimate, or generic orthocycline. Not tricycline, but cyclin, because I don't like the triphasic, I like monophasic. I like smooth, I don't like drama. That's the way I think. Cyclin, orthocycline, generic. Because I believe in generic. Generics are the same as brand name. But it's easier for the layman to remember that than norgestimate-based. If that doesn't work, then there's another one, drospirenone, but that one has a diuretic effect. And so most teenagers aren't good at drinking water, and they don't go to the bathroom at school, so then they end up with a headache and complain. And so I don't start people on that. And if they have an underlying kidney disorder, it can bring it out. And I don't want to do that unnecessarily.
What is the name of that?
Drospirenone, it's also known as Yaz or Yasmin. So it became very hot for a while because it was the new drug and every doctor thinks the latest drug is the best thing. But I was like, teenagers who don't drink water and complain of headaches to begin with, you don't want them having a diuretic because it's just gonna bring more headache, literally.
So, not to be the devil's advocate here,
Yeah.
I always think using less medication is better than more medication, but you're saying in certain situations, it's still more advantageous to make sure they're covering everything.
Yes, yes. So the question was, less medication in general is a good idea, but in this case, I'm advocating medication. And what it is there's a derangement, and I want to fix it. And I don't want to fix it every 3 months. I want to fix it all the time, because the time when it's not fixed, it's causing acne, it's causing hirsutism, it's causing weight gain, it's causing bad lipids. And so if I can fix it all the time, then you're healthy more days out of 365 than just that. We're just taking care of the uterus in that case, if we do it every 3 months and just clean it out every 3 months with the progesterone. But if you put them on birth control pills, what's interesting is, the way I think of it is, PCOS, your hormones are all out of whack. And by putting on the birth control pill, we take you to normal. And what's interesting is we tell people, you're gonna be infertile and you're gonna have a hard time getting pregnant. But ironically, the minute you get off the birth control pill, you're most fertile, because that's when you're most normal. And then as we take you off, you get more weird again, and it's gonna be harder for you to get pregnant. But people hear, oh, I got PCOS, it's gonna take a hard, long time until I get pregnant. No, you miss one of those birth control pills, that's when you get pregnant. Or like, we got a couple months before we're gonna get pregnant. No. Right when you get off that is your most fertile, because we've normalized you. And then if we let you be the way you wanna be, you're just gonna get worse, and then it's gonna be harder to get pregnant. So it's a weird, again, another hard concept. You get the logic. And I think it's really understanding the logic, the biology behind how it works. So we talked about decrease this unopposed endometrium growing. We talked about decreased serum testosterone, and because of that, less hirsutism, hairiness, and less acne. If the BMI is greater than 30, then the androgen suppression may be decreased. So again, if you're heavier, the whole insulin kind of defeats us a little, kind of fights us. And so that's where kind of metformin comes in. Which we just talked about. Desogestrel has unfavorable changes in insulin sensitivity. Drospirenone is the one we talked about. It decreases a lot of testosterone, it decreases abdominal fat mass, and increases lean mass, but that's the one that has a little slight diuretic effect. So it's, if they fail norgestimate and they still have hairiness and they're willing to drink water, then I'll go to Yaz or Yasmin or Drospirenone. But if they don't drink water, then I know headaches are gonna come.
Yaz is the one that
Has a diuretic
it's
effect.
it's the 3 phases, right?
No. So the difference between Yaz and Yasmin is the estrogen level. So Yasmin has 30 micrograms of estrogen. Yaz, the way I remember is because it's shorter and therefore smaller, has 20 micrograms of estrogen. And what's also another random fact, Yaz has only 4 days off the period, or 4-day period, whereas this Yasmin, I believe, has the standard 7. So the triphasic is orthotricycline. But again, not for you to know, just for you to know that cyclin would be a good one to begin with, and if failing that, there is a stronger one, but sometimes causes a diuretic effect, and therefore you gotta drink water with it. Okay, oh, and this is stepping it up a level, so the anti-androgen. So if we put you on Yaz or Yasmin and you fail that, then we can add this on, flutamide, which is an androgen receptor antagonist, and spironolactone, which is another diuretic, but also has an anti-androgen effect for the hairiness and stuff like that.
Sorry, quick question. For taking birth control, like how long you have to take? Because you start taking since teenager, and you probably don't have like a parent plan, and you just continue to take the birth control until you have plan to have baby.
Yes. So you can take the birth control pill from your first diagnosis of polycystic ovarian syndrome until you're ready to have a baby. And there have been lots of women that have been on birth control for 20 plus years, got off it, didn't have any problems getting pregnant. But what's interesting is a lot of women will attribute their problem getting pregnant from birth control pills to the birth control pills, but it wasn't. It was because they had underlying polycystic ovarian syndrome, and it was hidden because 10% of women will have polycystic ovarian syndrome. But there's nothing wrong with taking birth control for that long period of time. And in fact, I'm a proponent of turning off your periods in general, regardless of whether you have PCOS, because the epiphany trying to get pregnant, the only reason we have a period is we didn't get pregnant that month. So every month we build that lining, we wait for the embryo, and if the embryo doesn't happen, we flush it down, right? In the old days, we would have 8 children. We would breastfeed for 18 months. We would have 100 periods in our lives. Now we're having 300 to 500 periods, and we're popping out eggs 500 times in our lives. And anytime you pop out an egg, you risk ovarian cancer. Anytime you turn over the endometrium unnecessarily, you're risking an endometrial cancer. So any woman who's bleeding could turn it off with the birth control pill or the birth control ring, or there's an IUD in the Norplant as well, or not Norplant, Implanon. Then you decrease the eggs coming out, and you decrease this lining turning over. And one of the top reasons women miss school or work under the age of 25 is bad evil cramps. So we should be treating that. And I ask women, are you going to do better on your SAT on your period or off your period? You're going to do better on your test on your period, off your period? In life, pitching, giving a lecture, I think the answer is clear.
What about the Mirena?
So the Mirena is an IUD with hormone, and that is a really good system. Everyone that's on it, their periods get lighter. 70% of the women that are on it, their periods go totally away, and it's progesterone. So it absolutely provides the hormone that we need to counter PCOS. And you set it and forget it. Technically, it lasts for 5 years, but the research has shown it actually lasts for 7 years. And so you just got to have a physician or a nurse practitioner stick it in. You're good for 7 years. So yeah, that's definitely a good option rather than taking a pill every single day. But if you're used to taking a pill every single day, you could do that. And then the vaginal ring, the woman just places it up. It's a drug delivery device. Doesn't matter how it's oriented or whatever, and just change it once a month. So those are some options. PCOS and insulin. So there's variability in the ovarian size and polycystic ovarian syndrome. LH accounted for 37% of the volume, but insulin accounted for 18%. So there's this effect of insulin on the ovary causing this testosterone thing. And the obesity causes hyperinsulinemia, lots of insulin. And you'll see that in some ethnicities, Latinos, African Americans, maybe Asians, where they get this discoloration of the neck and then armpits. And the parents have brought the kids in and they're like, we're scrubbing him, we can't get it off. And it's like, you're not going to scrub that off. That's insulin causing acanthosis nigricans. And insulin in a woman then causes polycystic ovarian syndrome, then causes the high testosterone, and then all the side effects of that.
That's the way it started for some women?
The insulin.
Insulin?
Yeah.
And
Yeah.
it backed up to
Polycystic ovarian
PCOS.
syndrome. Exactly. We really feel it's a weight gain leading to the high insulin, leading to the ovary, leading to the testosterone. That is definitely the mechanism for most overweight kind of women. So insulin sensitizer, specifically metformin, will optimize weight loss, will help the hyperlipidemia. The birth control pills does nothing for either of those, and may also be useful for people who are hypercoagulable.
I thought metformin was used for breast cancer. Am I wrong?
No, you're thinking methotrexate, which is anti-cancer drug. So metformin, methotrexate, two totally different drugs. Metformin is generally used to treat type 2 diabetes, but it's also been shown in adults with a family history of diabetes, if we start early when they're overweight, it prevents diabetes. And so I use it in my morbid obesity clinic before they get diabetes, but if they have high insulin, to normalize their insulin level so that they aren't fighting the insulin. It increases the peripheral tissue to insulin so that your body says, oh, there's insulin. It helps hepatic gluconeogenesis, which you guys know, this is all very technical. Sorry, this is doctor talk. But it decreases your insulin levels. It decreases your total testosterone level, and it's actually helped people with sleep as well. The major side effect of it is kind of a GI upset for people, but after a couple of months, not a couple months, maybe like 1 month or 2, it goes away. And I feel that if you start up slowly, I've given it to a ton of patients, and many of them have not had problems. So it's not approved for polycystic ovarian syndrome, but a lot of physicians do a lot of stuff off-label. For example, technically, albuterol has never been tested in kids specifically FDA approved, but now we're we're getting all sorts of drugs FDA approved. So there was a study comparing metformin versus metformin plus birth control pills versus birth control pills alone. Those who got comparing, let's look at what would be interesting. Comparing metformin to the birth control pill, the metformin made the body better. It decreased the weight, it decreased BMI and fat, and it also lowered the sex hormone binding globulin more than the birth control pill. Comparing metformin with birth control pill versus, nah, you don't need that. Comparing metformin with birth control pill versus metformin, that'll tell you what the difference of what the birth control pill does. The birth control pill raises the sex hormone binding globulin, and it decreased inflammation, and metformin alone had improved body composition compared to the combination.
How long did that study last? And what about side effects?
Good question. I feel, oh, here, in my notes. Thank goodness for the notes. I have 12 months of treatment, and the main side effects of that would be the GI kind of side effects that we had talked about before.
Oh, yeah.
Good one. Thank you. All right, and then in 32 adolescents, the metformin plus birth control plus lifestyle had a lot of good effects. HDL is the good cholesterol, and so they were able to increase the good cholesterol in that one. So just comparing the two, you can treat PCOS with just metformin. If you put them on metformin, then their periods will regularize. However, in adolescents, we like to prevent unplanned pregnancy, so we find the benefit of the birth control pill as well. The birth control pill has more to treat the hirsutism, the hairiness, and the acne, and the metformin is more the metabolic kind of treatment. So you could either do one or the other or together. Most people won't do both, and that's the irony, is the endocrinologist likes the metformin, because when you're an endocrinologist, all you know is metformin, and birth control pills are a little scary. When you're a gynecologist, all you know is birth control pill, so that's all you prescribe. And if you're adolescent medicine and obesity, then I do it both. Just more research.
Both of them at the same time.
You can. So if I have an overweight patient and I have hyperinsulinemia, I will definitely treat with metformin. And if I have a patient who has nothing to do with PCOS and they're just overweight and hyperinsulinemic, I will give them metformin because I feel, actually I have an endocrine colleague at UCSF, Dr. Robert Lustig, and if you want to see a cool video, he has Sugar is Toxic. It's on YouTube. I think it's got 1 million hits. He taught me that when a normal person eats 2,000 calories, if you have high insulin, the insulin steals 500 calories and turns it into fat. So then you only feel like you ate 1,500 calories, and then you'll eat 2,500 calories. And it's just this positive, horrible feedback cycle. Whereas if I turn off the insulin, you eat 2,000, you feel like you ate 2,000. And so there isn't this steal phenomenon. And so I like to, if I see an abnormal lab, I like to fix it. So if you have a high insulin, I get, as evidenced by this darkness in your neck, but I like to have a blood test just to back me up. And then I will treat it with metformin.
Dr. Robert?
Lustig, Lustig, and he has a great video on YouTube, Sugar is Toxic, and he himself has lost a lot of weight by cutting down excess sugar.
Thank you.
Yeah. So I think we covered it. So number 1 is lifestyle modification. Number 2 would be birth control pills. And then adding, well, it doesn't have to be the pill. It could also be the vaginal ring, or it could be an IUD with hormone. And then metformin is good for any kind of metabolic complications. So, and so.
This is really good. Thanks for doing it.
Oh, you're welcome.
Really good. Thank you.
Thank you all for coming out.